Hello friends, today we are going to discuss about osmotic demyelination syndrome. Osmotic demyelination syndrome was first described in 1959 by Adam and Victor who reported pontine myelinosis in alcoholic fish. On pathology, increasing number of manifestation sites in addition to the pons were detected. Central pontile myelinosis and extrapontile myelinosis were combined into osmotic demyelination syndrome. Exact epidemiological data are still lacking, as there is no clear distinction between osmotic demyelination syndrome and prior underlying disease. Overall, osmotic demyelination syndrome accounts for 0.4 to 0.5% of all neurological admission to the tertiary care system and 0.06% of all medical hospital admission. So etiologically, there are large number of underlying causes and relevant comorbidities. While most of the early publication describe chronic alcohol use and alcohol withdrawal as a decisive comorbidities. A more recent work, as well as some of the older work, describes foregoing hyponatremia as most common cause, occurring in 30% to 78% of cases. Severe hyponatremia, another common etiological factor, is liver transplantation, for which most relevant cofactor is hyponatremia, but it is a severe only in 3.7% of cases. Now, pathophysiology, most common cause of osmotic demyelination syndrome is hyponatremia. However, despite osmotic stress, not every patient who has hyponatremia develop osmotic demyelination syndrome. Simply expressed, the only patient at risk of osmotic demyelination syndrome are those who have experienced chronic hyponatremia and correction of hyponatremia. Chronic hyponatremia is duration of more than 48 hours and progression at rate of less than 0.5 mmol per hour. The background of these sequential changes during regulation of the cell wall. A decisive role for transition from acute to chronic hyponatremia is played by removal of inorganic and organic osmolyte from the cell with subsequent normalization of cell volume. The same process occurs during correction of extracellular sodium without rapid regeneration of osmolyte, leading to decrease in cell volume, although osmotic gradient with consecutive cell death. So, clinical course of osmotic demyelination syndrome is highly variable in its clinical manifestation. In contrast, its time course is characteristic and central to diagnosis. The triggering factor precedes the demyelination and its symptom by 1 to 14 days. So, a symptom-free and stable clinical interval is then followed by osmotic demyelination syndrome induced secondary deterioration. The symptom usually correlates with the site of manifestation, differentiated into pontine and extrapontine. The most common clinical manifestations are encephalopathies characterized by the vigilance disorder, qualitative impairment of consciousness, delirium, disorders of drive, memory, concentration, among others. This course can be oligosymptomatic or symptomatic. Now, central pontile demyelinosis. If pons and the corticospinal and bulbar tract are affected in central pontine demyelinosis, patient presents with frequent encephalopathies and sign of damage to the brainstem with corticobulbar pathway involved. The patients are affected by dysarthria and dysphagia. If corticospinal tract is affected, initial flaccid and later spastic tetraparesis of varying severity appear. If tegmental lesions are present, ocular and pupillar motility may be affected. In severe cases, symptoms may even lead to locked-in syndrome. Severe disorder of consciousness occur in 6.1% to 14% of cases. Extrapontine myelinosis and movement disorder. Movements in the MRI have revealed numerous extrapontine sites of demyelination syndrome. As a result, demyelination of basal ganglia, a wide range of characteristic extrapyramidal motor symptoms have been found, including dystonia, myoclonus, rigor, akinesia, and tremor. The course of movement disorder in extrapyramidal myelinosis is often biphasic. Early onset of extrapyramidal symptom is followed by second peak that involves chorioathetosis and dystonia. Little is known about rate of occurrence of individual symptom. In a small case series of patients with extrapyramidal manifestation, 60% have extrapyramidal motor symptoms. Much less described are ataxia, generally as a part of cerebellar syndrome with lesions of cerebellar peduncle. Then neurobehavioral disorder. Recent case series and case reports have described the occurrence of cognitive deficit associated with the ODS. So lesions can found in the area of the cortex and in the transition between gray and white matter. So cognitive symptoms include frontal dysfunction, concentration disorder, and psychiatric disorder. A further group of the patient presents with epileptic seizure that persists longer than potential epileptic seizure in acute phase of hyponatremia. In summary, the presumptive diagnosis of ODS is usually based first on the clinical picture and the codes. The following factors suggest presence of ODS, that is biphasic clinical codes, initially electrolyte imbalance or other risk factor, and appearance of pontine and extrapyramidal symptom after 1 to 14 days. Factors that do not support suspected diagnosis of ODS are symptom onset during phase of electrolyte imbalance and cortical symptom and lateralizing symptom. Now the diagnosis. Suspected diagnosis of ODS or more specifically CPM should be based on the presence of risk factor and compatible clinical courses. So suspicion is confirmed by MRI, demonstration of demyelinating site, typically localized in pons, cerebellum, and lateral geniculate body, thalamus, and and extreme capsules. Damage to the brainstem can be detected by electrophysiological diagnosis and supportive evidence. No correlation can be made between diagnostic finding and clinical outcome due to insufficient research data. Now about lab diagnostic triggering events. Principal predisposing factors are electrolyte disturbances, chronic alcohol use, and malnutrition, as well as previous liver transplantation. Therefore, suspected diagnosis of ODS should be supplemented or complemented by appropriate lab diagnostic and medical history. The lab parameter to be examined are serum sodium, serum potassium, liver values, as well as parameters for evaluation of nutritional status. For example, vitamin B12, methyl, malonic acid, folic acid, and phosphate in serum. If possible, the previous course should be evaluated, especially with regard to serum electrolyte values. Imaging. As a rule, MRI is more sensitive than CT for detecting typical demyelination lesion as morphological correlates of the ODS. MRI is also successful in providing evidence for milder course of disease. This has significantly improved assessment of the prognosis of ODS as diagnosis is more restricted to autopsy verified ODS after fatal outcome. MRI course and consequences. Demyelination site shows hyperintensity in T2 weighted and T2 fluid attenuated inversion recovery sequence and hypointensity in T1 weighted sequences. The sensitivity of diffusion weighted imaging is unclear. On the other hand, early diffusion weighted imaging changes without T2 or T2 flare demarcation has been described. On the other hand, some studies have shown that TWI lesion as well as T1, T2 or T2 flare lesions were detectable. Accordingly, TWI, T2 and T2 flare sequences should be considered equivalent for the purpose of detection. Likewise, no recommendation can be made with regard to optimal timing of MRI imaging. Positive MRI finding can sometimes be present as early as first day after onset of symptoms. However, cases have also been reported where MRI findings were initially incautious and first pointed to the diagnosis at follow-up examination. In general, in case of early incautious MRI examination, follow-up imaging should be carried out in 1 to 2 weeks later. MRI alone is insufficient for assessment of prognosis as neither initial size or nor changes in the size during course correlate reliably with the clinical outcome. Cranial computed tomography can also be used to confirm clinical ODS but has significantly lower sensitivity than MRI. The rate of positive cranial computed tomography finding increases over course of development, although detection rate does not match with that of the MRI. In contrast, however, CCT imaging is faster than MRI and is ubiquitously available. This makes it especially useful for swift exclusion of differential diagnosis. If CCT findings are inconclusive, then, however, ODS cannot be ruled out at either early or late stage. Then about nuclear medicine. Nuclear medicine method contribute more to pathophysiological understanding than the confirmation of diagnosis. For instance, based on metabolic analysis by means of PET scanning, the early focal hypermetabolism was described that showed partial reversal towards hypometabolism over course of disease. To evaluate nigrostrial dopaminergic system in EPM, 1999 Trodat and IBZM spec can be used. With this method, bilateral reduced uptake of metabolites in striatum corresponding to ODS lesion has been observed. Now, electrophysiology. Although electrophysiological diagnostic may follow ODS to be detected, especially in case of pontine and other brainstem lesion, they do not provide consistent and specific findings. Indeed, not even correlation with the current clinical symptoms or outcome has been consistently described. Now, therapy. The small, low amount of evidence on the treatment of overt ODS is based purely on case report and small case sales. A preventive approach in hypernatremia of varying severity is better documented. Important issues for prevention are a diagnostic determination of the cause of electrolyte derangement as well as acuity of derangement and the associated symptoms. Now, prevention. The severity of initial electrolyte imbalance and the rapidity of its correction appear to play a critical role. In severe hyponatremia, the rate of sodium correction does not seem to be quite as decisive. In case of severe hyponatremia, the ODS incidence is significantly reduced by very slow correction of sodium limited to 120 mmol per liter. The rate of sodium correction does not seem to be quite as decisive. In case of severe hyponatremia with relevant neurological symptom, infusion of hypertonic solution of 3% sodium chloride should be considered. In contrast, if neurological symptoms are not present, increasing the serum sodium with respect to cause of hyponatremia is of primary importance. For raising serum sodium levels, infusion rate and amount can be calculated according to the limits. The goal of every treatment of hyponatremia is initially to achieve euvolemia and then to attain a balanced osmolality. If hypokalemia is also present, it must be treated first. It is important to closely monitor the level of sodium and potassium as well as osmolality in the serum and urine. If there is significant derangement, monitoring should be done every hour. In addition, fluid intake should be limited and reliably balanced. Depending on the cause of hyponatremia, another potential approach is the use of vasopressin antagonists to enhance elimination of water without concomitant loss of electrolyte. The selective V2 receptor antagonist tolvaptan has been approved for this indication. Due to associated risk and lack of outcome data, however, use of this antagonist is reserved for severe refractory cases after careful consideration. The risks include danger of overcorrection, onset of hyperkalemia, danger associated with initial critical and highly frequent monitoring is of electrolyte and volume status. So this figure is demonstrating about the treatment approach of the uh, hyponatremia to avoid osmotic demyelination syndrome. If a serum sodium level is less than 135, then we need to search for the etiology. We will send the following investigations like serum osmolarity, urine osmolarity, urine sodium channel, urine and serum electrolyte ratio, and fractional excretion of sodium. If serum sodium is between 134 to 120, then it is coming under the category of the mild to moderate severe hyponatremia that we need to correct at the rate of 0.5 mol per liter per hour or less than 12 mol per liter per day should be the target. If serum sodium is less than 120 mol, then it is severe hyponatremia. It should be corrected with the help of 3% NaCl at the rate of less than 0.05 mol per liter per hour or less than 12 mol per liter per day. So, about clinical manifestation, it should be first be noted that significant proportion of cases, good spontaneous remission occur. The described treatment option all have a slow level of evidence, and can only be characterized as experimental. Animal studies have shown that overly rapid sodium correction has myelinotoxic inflammatory component. Based on animal experiment, case report, and small case series, have tested early treatment with dexamethasone, plasmapheresis, immunoglobulin, and with unanimous reports of rapid positive outcome. However, whether this was the consequences of respective therapeutic measure or merely spontaneous course remains an open question. Minocycline is another interesting substance with the anti-inflammatory and anti-apoptic effect for which data exists for other demyelinating disease such as multiple sclerosis. Among other effects, it inhibits the activation of microglial cells. In animal model, minocycline has been shown to have protective effect against the development of ODS after rapid sodium correction for hyponatremia. Furthermore, in experimental study and in case report, reinduction of hyponatremia after initial excessive rapid correction for sodium showed higher rates of prolonged survival. Thank you, guys.